Video regarding EKG and the heart in general. So this video we're going to be going over the cardiac cycle as well as the action potential of the heart, both the cardiac myocyte and the cardiac nodal cells. So after that, then we'll go over why the heart contracts the way it does and why it looks like it does when you do an EKG. And then after you get an understanding of this video, I recommend you go and check out my other videos where you get a little bit more in depth in the EKG interpretation. So without any further ado, let's begin. So this is the typical appearance of any action potential you will see from a cardiac myocyte. Okay, I know it looks kind of blank and scary, but we're going to fill in some of the dots, and we're going to be able to figure out what is actually happening in this situation. So we know that an action potential uses either sodium, potassium, or calcium, and we're going to use actually all three of those in this situation. So we will first start here with this baseline. This resting baseline is called the phase 4 of the action potential. So this is essentially where we have a resting tonic membrane potential, which is negative, and this keeps the heart from contracting. And so what's happening in this situation is your sodium channels are closed, your potassium channels are leaky, so they're constantly allowing potassium to flow out of the cell, which causes the cell to become negative, because if we have a positive ion in that cell and that positive ion leaves the cell loses positive, so it becomes more negative. It's kind of hard to wrap your head around it, but if you draw it out and you think about it, if we have a positive charge inside of a cell and we get rid of one of those positive charges from inside that cell now becomes more negative. So that's why we're at a negative potential down here. And this is phase 4. Okay, this is the myocyte of the heart. Now we're going to go into what they call phase 0. So phase 0 is this rapid, steep incline here. What happens in this situation is the sodium channels, rapid sodium channels, are going to open and allow the sodium ions that are held outside the cell to rush into the cell. And this makes the cell positive, which is seen here by this big long spike up here to the positive. So we went from a negative 96 millivolts to positive 52 millivolts. So that's a heck of a jump. That's a 150 millivolt difference. And that's all because of the sodium ions are flowing in right through those sodium channels that have now opened. So now we're going to go and we're going to hit phase 1. So phase 1 is right up here, right after this little peak. And what happens in phase 1 is our sodium channels close and our potassium channels and our chloride channels now open. Okay, and so what's happening here, that's why we have this little spike here, this tiny little divot. And what's happening here is our potassium channels are opening. So now they're not just leaky as they were down here in phase 4, they're actually opening. So the potassium floods out of the cell. It's leaving that cell, so it's making it more negative. That's why we have this little drop here. We also have chloride channels that are opening, allowing chloride ions to flow from the outside of the cell into the cell really quickly. So both the potassium leaving and the chloride ions coming into the cell, both of those are going to make the cell become more negative, and that's why we have this little negative, this downward spike here. So we're starting to come back to our resting negative 96 millivolt potential. But you see that it levels out. So why does it level out? Well, what happens here is we have our calcium channels open. So calcium now starts to flood into the cardiac myocyte cell. And what that does is that makes the cell more positive. So essentially we're having a war between the potassium channels opening and the potassium flowing out of the cell with the with the calcium ions flowing into the cell. So the potassium that's leaving balances out with the calcium that's coming in from a charge standpoint, and that's why we have this level phase 2 seen here. Okay, now we're going to go into this drop-off phase, which is phase 3. This is where the calcium channels close right up here. So now the potassium channels win, and you're going to have potassium leaving the cell, which is going to cause that cell to become more negative. And that's why the rapid drop here in phase 3 is occurring, which comes back down to phase 4, which is again the resting membrane potential at negative 96 millivolts. So that's the cardiac myocyte. This is the muscle cell of the heart. Now we're going to go into the nerve cells, the nodal cells, and they're a little different. I didn't go in as in depth as I did with this because they're pretty similar, but they're a little different here. We'll talk about that. So essentially what happens with these pacemaker action potential nodal cells is they are constantly just doing this up and down and up and down. So if you were to look here, if you ignore this top part here and here, these cells would look like they would just go up and down, kind of like just a sine wave, okay? If you guys can envision that. And what happens is when that sine wave reaches a specific point, such as seen here at negative 40 millivolts, then that triggers the action potential. And so what happens is our calcium channels actually open. And so calcium floods into the cell, and that causes our action potential here. Now you might be thinking, so what causes this sinus wave to be down here? That's actually from they call them funny channels or funny sodium channels, and those are just tonically leaky, and they'll leak in, and then they'll kind of be overtaken by other ions, and then the other ions will flush in and make it more negative, and then they'll be leaky again, and then they'll be more negative, and so it just is kind of an up and down type tonic deal. And if we want to have our heart beat faster, we take this resting membrane potential here that needs to be reached to trigger that action potential, and we'll decrease it. And what that does is that makes these action potentials be able to be reached at a lower, more negative value, and so that gives you a faster heart rate. So that can be done with pharmacological drugs, that can be done physiologically in the body, but we won't get into that here in this situation. So like I said, sodium leaky channels fire, that allows this little spike here. Then we get up into the calcium channels, where the calcium channels open. Calcium floods into the cell, makes the cell positive. Calcium channels close here at the top, and then potassium channels open, allowing potassium to flow out of the cell, making it more negative, and then it comes right back down to this resting membrane potential where it was before, and we re-enter into phase 4. Now the thing that's different about this action potential for the pacemaker nodal cells compared to the myocytes as seen here, so if we look at the myocytes, we have 1, 2, 3, 4, 5 different phases, while in the nodal cell we only have phase 0, which is this height one here, phase 3, which is the decline, and then we have phase 4, which is kind of like the tonic resting membrane potential. So again, phase 0 is this upward spike, that's due to calcium channels opening. Phase 3 is the downward spike, and that's due to potassium channels opening. And then phase 4 is the tonic sine wave appearing phenomenon that is triggered by the leaky, funny sodium channels is what they call them. So when all those are combined, we get this type of image. And this is just a PQRST wave on an EKG. And so now we're going to go in and talk about what each one of these waves is and when it is occurring. All right, so here's a crude drawing of the heart. This gray area that's highlighted here is the area of the heart that is depolarizing, okay? So, and then down here I have a QRS or PQRST wave complex, and this little highlighted box is the area that corresponds to this depolarization up here in the heart. So first we're going to start with the atria, which is equivalent to the P wave. So in the atria we have, I guess I should say, this arrow here is also the direction of the depolarization. So the P wave first is the depolarization of the atria, like we talked about. What happens is you have a action potential that's triggered from the SA node, the action potential flows down through the atria all the way down here, and it stops at the AV node, which is right in this general location. So up here it says we have our atrial depolarization is around 60 to 110 milliseconds. If we have left atrial enlargement, it can be longer. Also, if we have a mitral stenosis or regurgitation, that can also affect our rate of depolarization. So the generalized vector for our atria depolarization is to the left hip. Okay, so that is the direction of depolarization that our atria are undergoing. So since we have our typical lead, and this is kind of over the top unless you've seen my other videos, the lead 2 is down on the bottom left side, almost down by your left hip. So that makes sense as far as why we are having a depolarization that's occurring that looks positive in our QRS, because this is from a lead 2 standpoint. Okay, so keep that in mind for when you watch my other video. So that's the atria depolarizing. Now it reaches the AV node, which is here. The AV node is what corresponds with this PR segment. The PR segment then passes that depolarization onto the interventricular septum, which the posterior division of the left bundle branch of the heart is what depolarizes that septum. The vector is very small and it's to the right. So if we have our lead 2 lead down here, it's away from the lead 2, so we're going to have a negative spike in the QRS complex. That's what this Q wave here has seen highlighted on the PowerPoint. So it takes 0 to 20 milliseconds. If we have any more or any less, you can have, well, I guess you can't really have any less than 0, but if you have any more than 20 milliseconds, then you can start getting into some different arrhythmias. But that's pretty basic as far as that's the interventricular septum depolarizing. So it always goes towards the right, the depolarization vector. Okay. Now we go into the first part of the ventricle depolarization. So that is corresponding here to this first part of the R wave. So when this happens, we reach the apex. The heart depolarizes from the inside out. Okay, so it always starts on the inside, and then the electrical impulse spreads to the external tissue of the heart. So we have this upward spike here, which is seen. I'm sorry, we have the vector that goes towards our left hip, which is seen by this first upward spike in the R wave. But then you might ask, what about these two little guys here on the outside ventricles? Well, since we're dealing with vectors and each one of these arrows points to the opposite direction, they cancel each other out. That's why there is no negative or extra positive little blurb here on this R wave. It's only looking at the apex, because these two vectors, this one here and this one here on the lateral ventricles, are canceling each other out. So as you see here on the PowerPoint, it takes 20 to 40 milliseconds. And it goes from inside to outside. Next thing we're going to look at here is the rest of the ventricle. So again, it goes from inside to outside, as seen on the lateral ventricles, and that is what corresponds to the top of the R wave. The right side has a shorter and faster vector than compared to the left, so see how this is a smaller area, and that's because the muscle is smaller, because we don't have high pressure we're pumping against on the right side of the heart. Left side's thicker muscle, it's pumping against the systemic pressure, and that's why it's a bigger vector direction. So again, this points to the left hip, this one points away from the left hip, but since this one is so small and this one's so large, this vector over here is essentially canceled out. Okay. Then the last little blurb here, the S wave, is due to the ventricular depolarization on the top left ventricle. It's very small, small area. That's why we have a very small spike on our QRS complex. It is away from the left hip, which is why it's a negative spike. So then overall, when you look at your mean electrical axis of the heart, that's why it points to the left hip, because when we add all these vectors together, so the vectors of the atria point to the bottom left, the ventricle depolarization points to the far right, the axis or the apex of the ventricle points to the bottom left, the ventricle depolarization points to the bottom left, and then this other little tiny ventricle depolarization points to the top left. But when we add all these vectors together, we get our mean electrical axis is pointing to the bottom left, and that's why we put our lead 2 right down here. Okay, so here's a chart of our normal limits that we kind of talked about. This is very important to know. So we have our P wave. It should be anywhere from 0.06 to 0.11 seconds. And like we said before, this is due to our atrial depolarization. Our PR interval is that distance between the P wave and the QRS complex, and that represents the time from the depolarization of the atria to the ventricle depolarization. So if that's too long, then that means we have a problem in these fibers that are transferring this electrical signal all the way down to the bottom of the heart. So they call that a bundle branch block. So you can start getting with AV blocks in that situation. QRS complex needs to be less than 0.12 seconds. That's dealing with the ventricle depolarization. And our QT interval is the distance, so we go back here, the distance from here to the end of the T wave represents the ventricle depolarization and repolarization, and we want that to be, it kind of varies depending on your heart rate, but that's typically at 60 to 100 beats per minute. It's around 0.3 to 0.4 seconds. Our T wave, we didn't really talk much about. That's this wave here. That's due to the repolarization of the ventricles. We usually want that to not be super far away from the QRS complex, but it really varies depending on the person. Excuse me. Our last slide here today, we're going to talk about how to find the rate of the heart using a quick little cheat sheet. So we're going to ignore all this up here. This is the way you can find it if you're mathematically, if you have the ability to do mental math of fractions and stuff in your head. I'm a med student. I don't have time to do crunching numbers in my head and things like that when we're in an emergency situation. So to find a rough heart rate, you can look at the EKG and just do a quick glance at it and you'll be able to tell what it is. So the way you do that, each one of these boxes is on an EKG strip worth a specific amount of time. Now, each one of these boxes is also divided into the tiny little boxes that you can see as well. So when we're going to calculate our rate from just using this strip without anything else, you need to make sure that you start at a QRS complex to QRS complex. You're going to measure the distance. So the way you do that here is each one of these big boxes is equivalent to a specific number. So it starts, there's no really pattern to it, it just starts at the top. So 300, 150, 100, 75, 60, 50. So what you're doing is the distance between this QRS complex and this QRS complex is what we're measuring, and then we're going to approximate our time, our heart rate off of that. So 300, 150, 100, 75, 60, 50. It's a little below 50, so we'll say 46 or 47, and that's what they actually said up here is 47. It's just a straight memorization thing. You always have to measure, or I'm sorry, you always have to count the big boxes and just memorize 300, 150, 100, 75, 60, 50. So if we had a QRS complex that was here, and then a QRS complex that was here, our heart rate would be 300. If we had a QRS complex that was in this location and then one here, that would be 150. If we had one that was here and then one that was down here, that would be 75, so on and so forth. And that's just how you can find a quick little way to calculate your heart rate without doing any math. So it's great in the clinic, and it's also great on tests. So that's the conclusion of this video. We'll see if I get around to making anything else today. But again, if you have any questions, please feel free to send me a message. And if you have any suggestions or questions that you want to have addressed on YouTube videos, also send me messages and I'd be happy to take care of those. So thanks.